Welcome to the Bringing the Human Back to Human Resources podcast. I'm Traci Chernoff, and I've spent my entire professional career in HR. Each week, we'll explore the delicate balance between people and business with the aim to reconnect the two and create meaningful outcomes. Listen in as I share my own experiences, challenge the status quo, and chat with guests from various industries about our mission to bring the human back to human resources. Hi, everyone. Welcome back to the Bringing the Human Back to Human Resources podcast. Thank you so much for being here for another week. Don't forget to rate, review, subscribe, share it with a friend, do whatever you've got to do to amplify the podcast and my fabulous guests that I have on most weeks because we appreciate it. And thanks for being here. So this week, we're talking about a very riveting topic, which kind of all comes down to insurance and benefits and things that really impact people very deeply and companies very deeply. And so to talk about this, I have Chris Hamilton on, who is a partner at Hotchkiss Insurance in Texas, where he leads the employee benefits consulting practice. He specializes in managing healthcare and insurance costs to improve benefits coverage, reduce expenses, and enhance employee health outcomes. With over a decade of experience in corporate finance, Chris has advised clients across various industries, including private equity and oil and gas. And in his free time, he enjoys traveling, working out, attending live music events, and of course, spending time with family. Chris, thank you so much for being here and for joining the podcast.
No, Traci, thanks for having me. Pleasure to be here.
Of course, of course. Well, I had shared this with you right before we started recording that we are recording this episode effectively at the end of my company's, like where I work full time, open enrollment period. And I had shared that this open enrollment and this particular cycle, we were met with significant increases in insurance costs for various reasons. Of course, companies generally see this, the cost of healthcare if people on the team are really sick or, require a lot of continuous medical attention, for example. So naturally that's a thing. And I'm also aware that across the country, healthcare premiums and insurance premiums have risen quite significantly. I think the website, keep me honest here, I think it's like healthcare.gov or something like along those
exchange.
Lines, right? Right, yeah. Exactly. So we can see that this is not unique to my employer, but that this is something that's generally happening or happened for 2025. So I am most curious to understand from you how employers kind of interact in these moments, because it puts so much pressure on the employer to figure out, like, what is their funding strategy? How do they do the right thing? Do we need to switch to different plans in order to give employees the best benefits possible while not, breaking the bank, so to speak? I mean, when we're talking about, I think most people know that payroll and benefits are like the most expensive part of running a business. And if a company has like $5 million cost on their healthcare premiums, like when you go up 50%, you're talking about millions of dollars. So I'm curious about your perspective on that.
Yeah, there's a lot to unpack there. I will say, for any employer that's listening to this was a really painful year for most employers nationally. A lot of the surveys that have come out have given a national average increase of about 9.5% to 10%. And just to put that into perspective, this is a really hard market, probably the hardest market we've had for cost increase in the last 15 years. And there's a number of things that attribute that to. But what I would just say from what the employers that we work with, and we have clients primarily in Texas, but we do business across coast to coast. Most of the mid-sized employers out there, and that's employers that have 100 to 2,000 employees, they're not seeing 10% increases. On average, they're seeing closer to 20. And it's this convergence of a number of things. One, we're coming out of this post-COVID economy, if you will. And if you look at the cost to operate hospitals in particular, on average, it's about an average operating cost increase of about 10% a year. And when you look at what Medicare, Medicaid, and other government programs are reimbursing hospitals, it's not keeping pace with that operating inflation. And you can't negotiate with the government. So where can these hospitals negotiate with, right? It's commercial insurance, and it's the Blue Crosses, United Health, Cignas, and Aetnas that all the employers nationally are buying into. And so they're seeing increased cost demands from hospitals. They're leveraging out higher reimbursement rates. And what people need to understand is the more we're paying for healthcare inside of hospitals and prescriptions and doctors' offices, insurance costs have to rise to cover that and provide a profit to the insurance companies. Okay. And so you're seeing this fight happen coast to coast, where in big cities, you'll have one of the major hospital systems that threatens to drop out of network with one of the insurance carriers. Well, the insurance company at the end of the day, whether it's United Health or Cigna or Blue Cross, they need that hospital system in network. Otherwise, they risk losing employer groups. So at the end of the day, they're going to come to some sort of agreement where they're going to agree to pay the hospital what they want, because the hospital has leverage in that situation. And what it ultimately results in is higher costs to those that are on that insurance plan. And the reason why you're seeing this now, because COVID's been somewhat in the past, over the last couple of years, but these contracts are multi-year agreements. So they're now coming up for renewal, and hospitals are demanding higher pricing. You're seeing that being passed on, along with just this overall confluence, if you will, of large claims that are happening nationally that insurers have to help cover. So there's a number of things to address this. I mean, I would say the first thing that most of the employers that we see, they're looking at alternate ways to structure their insurance. Benefits, as you mentioned, it's a really important cost, not just for operating a business, but for retaining and attracting the talent. We're in a talent war right now. And so a couple of things to keep in mind is, how does an employer's benefit, not just the coverage, but the cost, how does that compare to their peers? And I talk to a lot of employers that are mid-size all the way up to national publicly traded companies that don't really look at what is it that we offer and how does it compare to where we're trying to pull and retain talent from. And so that's kind of the first step. The second step is, how do we design our insurance? And most companies are used to buying insurance through a broker with one of the big traditional insurance companies. So name any of the ones that I just listed off. And part of the issue that we see with that is the big insurance companies, it's the way they make money. It's the incentive. And I think, Charlie Munger, Warren Buffett's right-hand man, once said, show me a man's incentive and I'm going to show you the outcome. And if you look at the incentives that insurance companies have, they don't have the same incentive that you or I do, or a business owner or HR leader listening to this. They don't have the same incentive that we do, which is to offer better coverage at lower cost. They actually have the opposite incentive, to see costs go up. And in fact, they participate in those cost increases. And it's one of the problems that we see with insurance today. So the first piece of advice that I give to HR leaders and executives that are looking to tackle this particular issue of what does it cost and how do we provide better coverage is, how does your insurance company make money? Where are their misaligned incentives and where are there inflated costs that you don't see? We have to uncover those. And so I would describe it this way. If we're paying $1,000 a month for a medication, and this is a life-saving medication that the member actually needs, like, that's really important. We want to make sure that that's covered. But what if you could get that same exact medication, the name brand and everything, and it was only $300 a month? That's a 70% cost reduction. And how many of those occurrences are happening inside of the plan that we have? If you can wring that waste out, you can reduce the cost of health insurance and keep the coverage the same. And what many employers are figuring out is, if we're able to do that exercise and it works effectively, wow, we could actually increase the coverage that we have for the same cost, or even still reduce costs. There's that much waste in the system. And so I'll kind of go back to how traditionally insurance companies are making money. There's a provision in the Affordable Care Act that limits the amount of profit that an insurance company is going to make at the insurance holding company level, which makes sense. We don't want insurance companies taking our premiums, denying all of our claims, and making a really fat profit by doing it. Right? That makes a lot of sense. If they're going to take our money, they should be obligated to pay a certain percentage of it for our healthcare. Well, the unintended consequence of that is these companies are publicly traded. And if you're the CEO and CFO sitting around the boardroom thinking, how are we going to show a return to shareholders? We've got to figure out, how do we get the pie to grow so that our 15% every year becomes a bigger number? So the immediate incentive is, how do we get premiums to spiral upward so we can take 15% of a growing number, is one. And the second thing that these insurance companies have done, and this isn't new, but it's really accelerated since the passage of the Affordable Care Act, is they've become vertically integrated, which means if you look at any of the insurance companies, they own their own PBM, the pharmacy benefit manager. It's simply a middleman that's setting the contracted price that insurance companies pay for drugs. But that's a mechanism that they use to shield profitability that's accepted from that 15% profit margin they're allowed to make as an insurance company. So they've done that. They now own physician groups, facilities, clinics, pharmacies, specialty pharmacies. So they're very vertically integrated. And those entities that kind of sit as subsidiaries systematically overbill the insurance company to show that they're spending money, overcharging our businesses and overcharging our employees and members. And at the end of the day, they come back to an employer and say, your loss ratio or your claims utilization is high. Therefore, we need this is justification for us to increase your premium. But if you're to pull each of these companies' filings, their 10Ks and 10Qs, you're looking at quarterly and annual data. If you look at where their revenue and profitability is derived, it's almost primarily from these subsidiaries, not the insurance companies. So the insurance companies will run lean. All of the money is being captured in their verticals. And so the thought that these insurance companies would have, and I know I'm rambling here, but this is really important for people to understand, is vertical integration is not necessarily a bad thing. Think about Amazon, for example. The value prop to them is to be able to deliver something to your doorstep same day or within 2 days. They used to rely on FedEx, USPS, and UPS. All that money that was being captured as profit to those entities, they were able to wring that out by building their own shipping fleet. And the value is now passed on to the customer. Insurance, it's the opposite. The value that's created by this vertical integration is captured for shareholders. And you can see it in 2 ways. 1, their profitability and their stock price continues to climb. And 2, the end user, the customer cost continues to climb as well. So I would argue that vertical integration is actually for the benefit of shareholders, not the membership. And the insurance company's fiduciary obligation is to shareholders, not the members. Once you understand how the insurance companies are designed and how they make money, the question then becomes, as an HR leader and an executive, is, okay, we understand that mousetrap now. How do we get rid of those conflicts of interest and misaligned incentives? And how do we design a plan where everybody's actually aligned with the goals that we have, which is top tier benefits, the best coverage possible at the best possible price? And that's usually where we start that conversation.
That's really, really helpful. I have so many questions coming out of what you shared, and I'll try not to throw them all at you at once. The first question is kind of going back to what you were saying around like understanding the goal of an insurance company. And I've seen your TikToks. I've seen the one that you kind of went viral with the urgent care. And I saw a lot of the comments where people are like, insurance is a scam. And of course, this is the widely held belief. And one of the questions that I have is kind of around what really helps drive profits for insurance companies. Is it maybe let me backtrack for a second. I think most people say, at least this is what I read a lot online and just, kind of see in terms of people's skepticism over insurance companies, which I'm not saying they shouldn't be skeptical. I'm just saying this is generally the vibe, is that insurance companies want us to be less healthy because then they make more money. And that the more we require coverage, or the more coverage we require, the more we need our insurance, the more money they make. I have family and loved ones who work in healthcare, doctors and others, and they say, well, no. And there is a second question that I have here. So I'm glad that I saw that you were writing something down, because I'm going to probably throw a couple of these at you at once. But they sometimes say, well, yeah, however, insurance companies make more money when people are paying high premiums and not getting sick. So when people are healthy or healthier, insurance companies are making more because they don't have like these crazy costs of coverage. And that's why you see, benefits like gym reimbursement and things like that in insurance, which arguably $200 a year is not a lot, but when you add it or multiply it by hundreds of thousands of people, that obviously adds up. So that's the first question, is like, what actually makes insurance companies money? And the second question that I have here for you is actually around the healthcare side and the healthcare provider side, because I have, loved ones in healthcare. They often say that they're in the last like 5 years or so, maybe even in the last 3 or a little bit more, there has been a huge reduction in reimbursements to healthcare providers from insurance companies. And it's forced healthcare providers to join hospital networks rather than, retaining or remaining in their private practices. And so one of the thoughts that I had as you were sharing all of this is there, and maybe you don't know the answer to this, but maybe you have a belief, is there a correlation between insurance revenue and being like really focused on hospital networks because they have, all of these, the x-ray machine is there, the CT scanner is there, like everything is there, versus private practice where maybe costs are a little bit lower for some people. I could see it varying. And so insurance companies potentially have this like underlying motivation to see everything exist in hospitals rather than seeing, greater reimbursements for private practicing physicians or healthcare providers, because maybe they're able to keep costs lower and that impacts the insurance company's bottom line. So these are two questions. I know they're big questions, so feel free to break it down, but I couldn't help but ask that.
Yeah. I have like a bazillion thoughts on all of this because you're asking the right question. In questions, these are the questions that HR leaders and executives should be asking. And because what you have to really understand two different things. There's an insurance, health insurance, and then there's health care. We often confuse them as one because health insurance pays for health care, but health care is a completely separate business than health insurance. So let's talk about the healthcare side first, because this is what drives the cost of health insurance. So your question about independent practices versus hospital systems. Hospital systems have, this is happening everywhere in the country right now, and it has been since the passage of the ACA. What you're seeing is hospitals have purchased other hospitals. So they've consolidated. They've done something similar to the insurance companies where they have vertically integrated. Because if you're a hospital, this is the brick and mortar building that people walk into. How do we get the patients in the door of the hospital? You've got to have steerage. So the pitch was, the Affordable Care Act and electronic medical records and compliance is going to be really difficult and expensive for you as an independent provider to do this. Join our hospital system. We'll take care of that for you. We can give you referrals. You give us referrals. And so what you've seen is hospitals have purchased other hospitals. They've consolidated. They've purchased primary care physicians, specialists. So the OB-GYN, the oncologist, the dermatologist, they're purchasing all of these providers. They're building physical therapy clinics, outpatient surgical, imaging facilities, all to create a single ecosystem so that no matter where somebody goes in to the healthcare ecosystem, they've got a solution for it, which it makes a lot of sense. There's continuity of care, there's simplicity of medical records and those sorts of things. But what you see happening is a member may not go to a primary care doctor. They may just go straight to an orthopedist with a knee injury. Since that orthopedist is owned by a hospital system, they're directed on where they're dictated to essentially where they can send patients. You work for us. When you order an MRI, you're sending it to a hospital owned facility that we own. And when that surgery needs to be performed, you're going to do it inside of our hospital. And all of that results in a higher cost because what's happening with the hospital to the insurance company, they're now, I'll call it just the too big to fail theory. This is back from the financial crisis where the banks were too big to let fail. I'll call this on the insurance spectrum. It's too big to not allow. And that is, we are the big hospital system. We're the 800-pound gorilla in New York City or Houston, Texas, or LA, California. You can't afford to not have us in network. Therefore, you're going to pay us what we need. And we're going to do everything inside the walls of our ecosystem. And ultimately what you see, and we call this side of care, you see this every day. A doctor, since we'll stay on the orthopedic condition side. So somebody has a knee injury, that orthopedic needs to order an MRI. Sending that to the hospital for that MRI is about, in my markets, about $2,500, $1,500 to $2,500, depending on if it's got contrast or not. So let's just say $2,500. But if they were willing to go to a freestanding imaging center, same MRI machine, they're all made, there's only a few makers of those machines. It's all digitally transmitted. That image can be shot, sent to the orthopedic doctor. You can get that same image for $400 or $500. So if you are a provider of benefit an HR leader, and you understand that the cost of healthcare is going to drive the cost of your insurance, do you want to help your member get the $500 image that's the exact same quality? Because you can provide 5 of those images for the price of one.
Mm-hmm.
So site of care becomes an important issue. And there's ways that you can design a plan to incentivize people to have a choice. But that's really what's happening on the health care side, just to give people kind of a little flavor of what's happening. On the insurance side, to answer your question about how insurance companies are making money, it makes total sense for any business leader. Revenue minus cost is profit, right?
Mm-hmm.
But insurance math doesn't work that way. So for an insurance company, their profit margin is capped. For this, when we're talking about large employers, and by law, a large employer is identified as somebody that has more than 50 full-time equivalent employees.
Mm-hmm.
So that's what we're talking about.
Mm-hmm.
So an insurance company that has a block of business nationally with large employers, has more than 50 employees, they can only make 15% profit margin. So that's revenue of premium, all the premiums everybody's paid in minus all of the healthcare costs. If they make 16%, 17%, 18%, which this happened during COVID because people weren't using insurance because facilities were closed,
Mm-hmm.
they have to return that premium back to the policyholders, anything above 15%. So if they're making a 20% margin, they're giving 5% of that back to all of the companies that paid in. So their margin's capped. This is where the vertical integration piece comes in. And so what insurance companies really want, I'm just putting my insurance executive hat on here. I need people paying premium in, and I really need people to use the insurance, and I need them to use certain things. I need them to use prescription drugs. I need them to use the doctors and the facilities that we own primarily. If you're one of the big insurance companies, people think of Aetna as an insurance company. It's actually owned by CVS. And
Mm-hmm.
what else does CVS own? Massive pharmacy chain. They own an insurance company, Aetna, and they own one of the largest pharmacy benefit managers that's setting the price that insurance pays and what the pharmacy they own pays. What could possibly go wrong? You talk about fox guarding the hen house. Is there anything wrong? It's like asking the fox, is anything wrong? And he coughs up a bunch of feathers and says, definitely not a problem. Right? That's exactly what's happening.
Yeah.
And so what insurance companies want is people to, I don't want to say they want people to be sick, but we need people to use the insurance, but not too catastrophically.
Mm-hmm. They want people to need coverage of some kind.
They do. And at the end of the day, people think that insurance companies are the ones that are taking all the risk, and they're not. It's not their money. The way to think about an insurance company is they're a middleman between the healthcare that's provided and the people that actually pay for healthcare, which is employers. About half of Americans are getting insurance through an employer.
Mm-hmm.
So the real power is in employers' hands to solve this problem. They're the ones paying for half of healthcare in the United States. And what most employers don't realize is that if your claims are high in a given year, you just experienced this with your own company. You got an increase, right?
Mm-hmm.
The costs are going to be shifted back to employers no matter what. So the onus, we think, well, I'm locked in for a year with this insurance company. No matter what happens, I mean, my price is guaranteed, but no, is it really? It may be guaranteed for a 12-month cycle, but in month 13, you might get a really big increase. So it's really incumbent upon all of us as leaders to figure out what's really driving cost and what can we really do about it. And so I don't know if that really answers your question, but I go back to the way insurance companies make money. If you look at their financial statements, it's through the usage of the healthcare system, and it's particularly things that they have ownership in. And I think that's one of the biggest problems that the current administration is going to have to address. You see little bits and pieces of them trying to address it, but institutional ownership of the healthcare ecosystem by publicly traded and private equity backed companies is a real problem.
Yeah, I totally agree. I also think, we often on this podcast, we talk about kind of that intersection between regulation and lack of regulation, or where, companies can do their own thing and where government sometimes needs to step in, whether it's local, state, or federal. And I have been reflecting on this recently that, it kind of feels like things have come to a point where employers are doing a lot. Maybe there are some who need to do more. And now there's obviously I think, obviously, a need for the government to kind of step in and say, hold on, like, is this really what can happen here? Because at some level, I think the government does care about employers staying in business in order to employ people. And when costs just year over year rise so significantly, on top of all of these other costs that rise significantly, whether it's groceries or gas or, electricity, whatever it is, right? Those things, they all like play a very significant role in how employers can actually conduct their business. And when I think about just the rising cost of healthcare coupled with how insurance companies make money, I think this is where sometimes regulation steps in to say, okay, hold on. Sure, you're a business too. You're publicly traded. You have stakeholders and all of the shareholders and all of that. However, we're also talking about people who you are kind of requiring to have insurance, because also when even though certainly people can get care and coverage without insurance, there is obviously a financial burden there. Some people are starting to make the argument, not many, but some, in a niche way, that not having insurance is less expensive sometimes. Like, it kind of depends on what their circumstances are. And so I could see for sure the need to have more regulation, or at least like government interference in some of these things. And I'm curious also because, at least in my experience as an HR leader, through all of the open enrollments that I've kind of been a part of or conducted, it seems most of the time, the larger the team, the lower the costs on employers can be in terms of plan premiums and how effective their funding strategy can be. But I'm curious if there's statistical significance there. Like, if it's just that, well, you can have more employees and you can have a greater percentage of them who are actually requiring more significant healthcare. And so it kind of comes out in the wash and it doesn't really matter. Or, because also like this idea of large employers, large businesses being 50 plus, most people would probably think a large employer is way bigger than that, but it's because small businesses are under 50. So I'm curious if there is kind of a correlation between business size and cost of healthcare in terms of, I should say, cost of insurance premiums on the employer. And then obviously sometimes that does translate to the employee too, if the employer can't cover or refuses to cover in their funding strategy more of the cost of coverage.
Yeah, I think those are great questions. In my experience, what you'll find is there's smaller employers, and let's just even use this definition of 50 or more employees inside of an employer. Let's just use a round number, 100 employees. Mm-hmm. That company might spend $1.2 to $1.5 million a year in health insurance premiums. Mm-hmm. Is that statistically significant risk dispersion? And I would say no, that's not for health insurance reasons. And I would tell you, we used to measure the size of a large claim. If a claim was over $100,000 15 years ago, that was a notable claim. And then it was 250, then it was $500,000. A few years ago, we started measuring claims at the $1 million mark and more, because it used to be very rare to see that. But we see it quite frequently now. And now the catastrophic claim threshold that we monitor is this $2 million limit. So somebody gets we have the blessing here is that we have the technology and the capabilities to treat people with a multitude of illnesses and conditions that we used to not be able to treat. So that's the blessing in disguise here, is like we can now treat things, but there's a price tag associated with it. So you might have an employer with 100 employees that's paying $1.2 million in premium, and they end up with a $1.5 million claimant, a premature baby that's in a NICU, neonatal intensive care unit for 3 months. And that could be $1.5 million or $1 million or more.
Yeah.
So just in one person, the insurance company has paid out more than the group has paid in premium. So what do you think is going to happen to that group at renewal, right? They're going to probably expect a sizable increase. Right. But there is a law of diminishing return. I mean, that holds true. You do need a significant size of employees to disperse the risk. It's similar philosophy to investing in our 401k. We're not taking our 401k money and putting it in single stock. Why? Because that would be crazy. It's not diversified. So what do? We buy a mutual fund that might invest in 200 or 300 other companies, and we'll buy 3 mutual funds. So in aggregate, we've got a little bit across 2 or 3,000 companies, we're diversified. Hopefully we've picked different industries and different size companies and the whatnot. And so what we see employers doing today is that similar strategy to manage their insurance. And so we see employers, we're grouping them together around the country where you might pull together 1,000 employers in a common pool, and there might be 10 or 15,000 employee lives in that risk pool, if you will. And it allows a smaller employer that maybe has 100, 200, 500 employees to now buy insurance at scale because they've been able to diversify their risk. That's just one component. If we're all doing our insurance through one of the big 4 insurance companies and we allow them to monetize our claims through their vertical, that's going to result in higher costs. So the ultimate best outcome where you have the best of both worlds is you're pooling together employers that have a similar mindset to say, we're going to align our plans in the right way, where we're buying pharmaceuticals the right way, we structure the plans the right way, we create incentives where employees can win and get low cost, no cost healthcare because we're buying it the right way. As those types of employers come together, you're able to offer more diversified risk, you're able to lower the cost of insurance, and you're able to lower the cost of healthcare. That really is the trifecta that we see. The employers that are winning in today's market, that's the direction that they're going. They've realized doing it the way we always have doesn't work. And you mentioned inflation. We talk about wage inflation, electricity, groceries, gasoline. What's interesting, if you look at gas, I don't know what the gas prices are in New York, but I'm in Texas.
$3.
Yeah, we're paying about $2.55 to $2.65 in Texas, depending on which market you're in. What's funny is back in 2006, 2005, I was paying close to $4 a gallon. I'm actually paying less today. And if you ask people what's something that's really inflationary, they'll say gasoline. Well, it might spike, but it comes down and it goes back up and it kind of fluctuates, right? But if you look at healthcare, and in fact, the Department of Labor has statistics on this, it's the most inflationary thing in our economy, insurance particularly. It is a hockey stick up and to the right above everything else. But if you look at other industries, like consumer goods, televisions, technology, I don't know how old you are, but I remember
33.
Okay, so VCRs, you don't know what that technology is.
I know of you. Oh, of course,
okay.
yes.
I remember as a kid, we walked
in 92.
Yeah, I remember as a kid, we walked into a Conn's electronics store, and I was a little kid, and we bought a VCR. We paid $750 for a VCR. You can't even find that technology now. But before it was old technology, you could buy them for, I don't know, $25, right? The first flat screen plasma television was $10,000. I can go buy something that's a much better technology for a few $100s. And what you see is there's consumerism. People have multiple places to buy them, multiple places to pay for them. They can read reviews. They have that entire information set in their hands, and they can shop and they understand how it works. Healthcare doesn't work that way. There's very few suppliers. There's very few payers if you're buying it through an insurance company, and there's a lot of power in very few hands, and there's no information. Nobody knows, what does a baby birth cost? Is it $5,000 or is it $50,000?
Totally.
Or the price of their medications. Most people don't understand what that is. So you can actually design that into your plan to where members at the touch of a fingertip with a smartphone know, if I go here, it's more expensive. If I go here, I can get it for free. So there's just a lot that can be done with this. And I know I just kind of rambled there, but there's so much here that for an employer to actually grab a hold of. And the last point I would make to this, because you kind of alluded to this, the role of an HR leader and the executive team in managing benefits. You're seeing a lot more of this come to light now, that the employer is a fiduciary of their employee benefit plan on behalf of their members. And you've seen some lawsuits. The big notable ones are going to be Wells Fargo and Johnson & Johnson, where the HR team, the HR leader, and the CFO specifically were named in these lawsuits for breach of fiduciary duty. And what that really underscores to me is the role that we all play, making sure that we have the right advisor that's helping us understand and properly vet the market. Because you can tell a broker or an advisor, go get us some options, but are they the right options? And did you look at all of the options that truly were available to you to provide the best benefit and to get rid of this waste? And the thing that people are looking at, the regulators are really looking at, is, are there conflicts of interest in your plan that you should be aware of? And you've allowed these companies to essentially rip you off and rip off, because in one of the lawsuits, the J&J lawsuit, they specifically cited a medication that was over $1,000 a month that could be purchased for $38.
Unbelievable.
And the member was forced to go through that channel and pay egregiously for something they didn't have to. But there's that pricing discrepancy inside of these insurance plans across the board. Mm-hmm. And as you solve that particular problem, that is how you bring down the cost of insurance and improve the benefit coverage to the employee and the membership.
That's really helpful. And actually, I think it's a perfect segue for one of my last questions for you, which is, if someone's listening today and they're like, oh yeah, the open enrollment process in 2025 was brutal. I never want to go through that again. This episode is coming out pretty much at the top of the year. So we have effectively like 9 months to figure it out and figure out how we as HR leaders can do better for not only ourselves, but our employees and our companies. What is something that they can do today that can improve their outcomes and, frankly, the experience for their employees and the company?
Yeah, wonderful question. The advice I give to leaders is start early. Most of the time, when we speak with groups, they're telling us we don't really address benefits until towards the end of the year. Mm-hmm. And really, benefits management should be a year-round cycle. There should be at least monthly or quarterly, at least, touch points where you're reviewing plan performance and options. And so when you get to the renewal, there's no surprises. And if a company is looking at alternatives, they should be talking to multiple advisors, because if you talk to 3 advisors, you might get 3 different opinions about what your options truly are. Mm-hmm. And a good advisor is going to ask a lot of questions. They're going to ask for some information, and they're going to do an assessment of your plan and provide you a strategic review that says, here's what you have today versus what your stated goals and plans are. Here's the gaps and how you address those gaps. And that really should happen before the midway point. So if somebody's listening to this in January and their plan renews in January every year, you really should be talking to advisors in probably April or May, preferably March, sitting down early in the summer, late spring, early summer, to set those plans of what your renewal is going to look like for January. You're making decisions in July based on what the strategic review showed you in May or June, so that you have a long enough runway to properly address the issues. Because what we see a lot of companies doing is they'll wait until August, September, when the renewal is about to be issued, and there's just not enough time to do a proper evaluation and a vetting process, because sometimes you're tweaking a plan that an employer has. Sometimes you're rebuilding it.
Sure. That makes total sense. I have a lot to think about here, thinking about the next 12 months or so, because based on when we're recording. Thank you so much, Chris. This has been more than a riveting conversation for me, and certainly I hope for the listeners also. Where can they learn more about you and what you do, and maybe even connect and follow your content?
Yeah, I appreciate that. I'm on LinkedIn, TikTok, TikTok and YouTube. I post long form podcast content where I really break down some of these contents on YouTube. The central hub where people can find me and get access to all of the materials, case studies, and content I create is a website called itschrishamilton.com. So it's me, it's chrishamilton.com.
Amazing. And we will make sure that everything is linked also. And I really appreciate you helping us to better understand a lot of the complexity behind this subject. So thank you so much. And come back, on the podcast if something changes in the insurance world, especially if the government ends up getting involved. I think that could be very interesting to break down. So we'll see. But in any case, thank you so much, Chris. Really appreciate it.
Thanks for having me. I appreciate it.
Hey, just before you go, don't forget to subscribe to this show so that you are the first to hear when an episode drops each week. And maybe leave a 5-star review and a comment about how much you loved this episode. Plus, if you have someone in mind who would really enjoy this episode, make sure you share it with them. Thank you so much for tuning in, and I will see you next week.